So welcome to a conversation about medications. We're going to try to make this lively, so we'll interact and ask a lot of questions. Because, unlike a topic, some of the topics I like to teach, like effective treatment of trauma or hypnotherapy, this has a level of technical detail that's even higher than that. So one of my objectives is not, we're going to leave here understanding all the medications and their pharmacological actions and all the drug interactions and food-drug interactions, so much as when you leave here, you'll have the material and a broad understanding so you can refer back to this stuff. There are people in this room who are likely using one or more of the medications we're talking about today. Maybe you'll learn something that could be helpful to you or somebody you love, because psychiatric type medications are among some of the more widely prescribed medications out there. And so let's jump into the material. I want to just do some broad stuff about medication administration. If you look at pharmacology in the US in general, it's a bit disturbing when you realize that about 20 to 30% of prescriptions written by physicians for patients never actually get filled at the pharmacy. Now, I'm not talking specifically psychiatric medications. If I had to make a hypothesis, I would guess that number would be higher for psychiatric medications than general medications. So people go to the doctor's office, they get a prescription that presumably they need, and they never fill it. And then about half of medications aren't taken as prescribed. One of the more common ones, I'm going to pick for a moment on my beloved father-in-law. I adore the man. I'm blessed with two dads. I respect and adore the man, but he grew up in the Depression era in Europe and tends not to throw anything out, which if some of you have grandparents who grew up in that era, you know what I'm talking about. There's this sense of you need to hold on to things for a rainy day. So let's suppose he has some sort of infection for which an antibiotic is an appropriate medication. Despite the fact that my wife, who is an experienced nurse, just gets on him all the time about this, he'll take about half of it until he starts to feel better and then save the rest for a rainy day because you never know when you might need it. And this is not a dumb person. He's a retired electrical engineer and had something to do with, those cool radar sensors and stuff a lot you have on your cars and backup cameras. He was somebody who helped engineer some of those systems. But about half the time, people don't take their medications as prescribed and then wonder why they don't work. A lot of people stop taking medications that they're really supposed to take on an ongoing basis. So one of the things we can do in leaving here and working with clients who are taking necessary medications is hopefully be a little better equipped or a little more aware of those kind of basic statistics. Because one of the more common reasons why someone who needs to be taking some sort of, let's say, depression medication might not be getting a very good response, might be inconsistently filling prescriptions, not taking them consistently, and that appears to be kind of almost the norm in our culture. I think it's fair to say that in our culture, psychiatric medications tend to be a little more controversial than some others. Oh, Ritalin's a good one. I hate that stuff. I'm never gonna want anybody to take that particular medication. But we have to be a voice of greater objectivity than sort of get into these politicized things that this is a bad medication. A medication is a tool. It's not bad or good. It depends on how it's used. I'm jumping ahead a little bit, but talking about the Ritalin thing, I could introduce you to people who will tell you that it saved their life. I could also introduce you to people for whom it was prescribed inappropriately and contributed to messing up that life. Is it the medication's fault? Yes or no? No, well, why not? Why isn't it the medication's fault? I mean, last I checked, it's just a little chemical, pill, right? It doesn't have a mind. It doesn't have a conscience. It all depends on how they're used and how adequate the communication is between the provider and the taker, between the pharmacist and the. So if you or people have some of these stereotypes that X is a bad medication, or if you bring any of those biases to the table, I would encourage you to kind of take a look at them. Because in and of themselves, a medication is neither good nor evil, right or wrong. It's just a chemical. It ultimately depends on the hands of the practitioner and the relationship between the practitioner and the person who's taking it as to what the outcome tends to be. So, do keep that in mind as we move forward. Traditionally, these are some of the broad categories that you see for the medications many of our clients may use. Okay, you can read those. Depression, mood stabilizers, etc. But I have a little bit of a disclaimer. Most real experts on psychopharmacology don't like these categories. Let's just pick a medication everybody here has probably heard of. Prozac. What is it? Which one of those categories does Prozac fall in? Antidepressant. Well, that was a loaded question. Have you ever seen it used for any of the other sorts of things up there? Okay. So is Prozac an antidepressant or is it an anti-anxiety medication? Okay, it can be, and it could be a mood stabilizer. So it's a multiple choice question. Is Prozac an antidepressant or an anti-anxiety agent? And the answer is your choices are yes or yes. Because one of the weird things that happens, I guess, is we put these medications in these rigid categories. And when it comes to psychiatric meds, those categories are really artificial. In fact, experts on psychopharmacology bristle at the term antidepressant, for instance. Because the antidepressant medications may have benefits for all sorts of things. Let's use another example. Zoloft and some of the other traditional antidepressants are often used to help treat chronic pain. That's interesting, especially in an era where we have this horrible opioid epidemic. Any sort of efforts to find alternative ways of managing chronic pain are worth talking about. So is Prozac an antidepressant? Sorta. It's also has some mood stabilizing properties, some anti-anxiety properties. It's also got some pain management properties. And you see it used a lot when people come to their physician and say, I've got lots of stress. And they leave with a prescription for Zoloft or something like that. Now, is that good prescribing? Maybe, maybe not. But so the first thing I want to just bust is while we're going to use these categories to help organize our conversation today, these are really permeable categories. Have you had this kind of thing happen? A child is on the autism spectrum, and this particular kid has major issues with aggression toward self, aggression toward others, biting themselves, other sorts of things like that. And a physician, ideally a psychiatrist, like a Dr. Ahmad perhaps, recommends Risperdal or risperidone. And the parent reads the blurb from the pharmacy, and what does it say? The first thing right on top of the thing, it says treatment for schizophrenia. And then if the parents weren't maybe paying really good attention or didn't understand what the nurse or pharmacist was sharing for them in the way of information, they get rightly concerned because they think that risperidol, if it's an antipsychotic approved for the treatment of schizophrenia, are either you gave me the wrong medication, it's a logical thing to wonder about, or my kid has schizophrenia and you're not telling me. Also a reasonable concern. But risperidone isn't an antipsychotic alone. It's sometimes also added to antidepressants or mood stabilizers to help with mood. In low doses, it seems to be one of the most effective medications for cutting the edge on some of that aggression for perhaps more severely autistic children. So let's use these to organize our conversation, but please put like a mental asterisk around all these categories. Why is this the case? Well, the truth is it's the case with lots of types of medications, not just psychiatric ones, but sticking within the realm of the psychiatric meds. Why is this, there's this permeability between these categories? And you know the best answer I can give you is we really don't know. So why don't we know? Well, I'm going to appeal to something some of you have heard me say before. Psychiatric medications, one way or another, influence the way the cells in the brain communicate with each other. We'll talk more about that also as we go through the morning. And there's a lot of unknowns about the human brain. There's a lot of unknowns about the human brain because it's absurdly complex. Roughly how many brain cells do you have between your ears? Now, if you've got kids, it might be less. It's good to hear you laugh. But about 100 billion. That's a big number. About 100 billion neurons in a typical human brain. How many synaptic connections does each of those cells have? Now, I've got some diagrams we'll show later, but all of you probably in high school or college bio class remember diagrams of nerve cells, and there's some nerve endings at one end, and there's a cell body at the other, and a axon, kind of like the wire in between. And that's lovely, but most of the cells in your brain don't typically look like that. That's more likely an example of what a cell in the periphery of your body might look like. But brain cells are way more complicated than that and have far more interconnections than that stereotypical image you saw in your biotexts. Neurons in the brain have an average of about 10,000 synaptic connections per cell. If you take out your phones and multiply 100 billion by 10,000, it will not fit on the screen. Unless you use exponents, if you math majors remember those things. That's a big number. It's something like 10 quadrillion, I think. So that's roughly how many synaptic interconnections you have in your brain. To put it in another perspective, again, some of you have heard this before, but for those of you who hadn't, in a young child, an infant, toddler, where brain growth is incredibly rapid, they add 700,000 new synapses per minute. That's why my 2-year-old granddaughter seems to learn 20 words every day. It's just crazy how much they can learn, and that they can learn multiple languages at that age. 700,000 synaptic connections per minute. So when you look at those numbers, quadrillions, million, all these kind of things, it should sort of humble us a little bit in understanding how absurdly complex this thing is. It's perfectly reasonable to say that the human brain is the most complicated thing in the known physical universe, period. Nothing. Galaxies, anything have a level of complexity. What, look, that 4-pound organ between your ears. Isn't that amazing? Compare that to your heart, a very vital organ, but it's a relatively simple thing. It's a 4-chambered pump powered by muscle and innervated by nerve cells that make it work. It's a pump. When it comes to the physical properties, it's not a whole lot different than the pump you might have in your well if you live out in the country. Works on similar principles. So cardiologists have it easy. Neurologists and psychiatrists, it's a whole different ball game. So we've begun to understand how our brain functions, but we've just scratched the surface. So anything related to brain functioning, and the broad definition of mental disorder is a disorder of brain functioning. It's really hard to answer the question exactly why something works. And to box things into these things into rigid categories becomes a problem because our brains don't really work in these kind of categories. For example, depression and anxiety. We separate them out for our convenience, but you hardly ever see one without the other. They probably ought to be hyphenated, you know? Because if I'm going through a period of depression, there's probably plenty of things I'm worried about, and vice versa. So you get the point. So I think we've said enough about that. So as we go through these categories, just remember that these categories are very flexible. And that's a good take-home point, because when you get questions from clients about, this is an antidepressant, why did doctor give it to me for this? Speak to that kind of thing, okay? All right, hope that's helpful. All right, so those are the broad categories. Because the brain is so complicated, and because the disorders we treat overlap, you do get off-label prescribing pretty often. Off-label prescribing is the idea that if you look at what a medication is officially approved for, the doctor may be prescribing things that are outside those formal FDA approvals. And it's part of the same theme. That does not mean the physician is doing something immoral, illegal, unethical. Off-label prescribing is pretty common throughout the medical industry, and it's an accepted practice as long as it's done with some thought. But I think it tends to happen more frequently in the behavioral health field because of that fuzziness of the categories. There are lots of factors that can affect a physician or nurse practitioner's decision as to what to prescribe. I mentioned FDA approval. It's not a rigid thing, but it's a consideration, of course. Level of functioning, diagnosis, history of risk. Of course, the client's history is going to be important. History of medication, cooperation. Someone's got a history of being pretty adherent and cooperative with medication. You may be inclined to take maybe a few more risks or be a little more aggressive with medication. A lot of this is fairly common sense. There are some medications that have a higher abuse potential than others, so that needs to be considered. We'll talk about that in some detail. I want you to notice something about the language I just used. It wasn't random. I said there are some medications that have an abuse potential. I did not say there are some medications that are addictive. There's a difference, and I would challenge you to be careful about the words you use. And I'm going to just kind of leave you hanging with that at the moment, because we're going to address that issue later. There is a distinct difference between those two terms and what they mean. Okay? Medical history, of course, history of side effects, and cost. One of the #1 issues people don't adhere to a medication regimen is concerns about cost. So one of the first questions I like to ask somebody if they're having issues with medication adherence is that a factor? You know, it's kind of a Maslow's hierarchy of need question. if I think you're not taking it because it's not helping you with your self-esteem, well, that's up here. Maybe it's because they're struggling with a choice of whether they buy the medication or eat. Okay, we got to be sensitive to that. That's a graphic of a synapse, okay? A synapse is the point at which two nerve cells interact. Now, I know some of this is old stuff for some of you, but it might be new for others. So for those of you that this is a repeat, try not to tune out, because out of respect for everybody, I want to make sure we cover the fundamentals. The wiring, so to speak, in your brain doesn't operate like the wiring in your house. If there's a wire, for instance, that runs behind your wall and allows you to turn on a certain lamp when you flip the switch, if there's a disconnection in that wire, at a minimum, the light won't go on. And at a maximum, you might have a fire in the house, right, from a short and a spark. Everything has to physically connect in order to work. That's not how your brain cells work. The cells, nerve cells, interact at points called synapses, and there's this tiny little gap between the end of one nerve cell and the beginning of the other. Those 10 quadrillion or whatever it is synapses look roughly like that. This tiny little space. So how do these nerve cells talk to each other, so to speak? Well, they talk to each other by moving chemicals across that space. It's a chemical messenger system. Okay, so the originating nerve cell releases a chemical that moves across the synapse and is received by the other cell, and that causes it to send the message onward. We will talk about that more later on. But for now, one of the take-home messages is every medication that clients take that are considered psychiatric meds do something at that point. That's the critical element in their action. They either speed up the movement of those chemicals from one cell to the other, or they slow it down. Basically, every one of them does that one way or another. They do it in lots of different ways, and I'll give you some examples as we look at specific meds and specific types. You've probably heard of some of these, maybe not all of them. There are dozens and dozens, probably hundreds, maybe thousands of neurotransmitter chemicals in your brain. There's only a handful that have been identified, but most experts are convinced there's way more to discover than we have identified at this point. So we know that certain psychiatric medications work on these different neurotransmitter substances, but they probably work on others we don't even know about yet. But these four are the biggies when it comes to understanding the mechanism of action of most of the psychiatric medication. Dopamine, GABA, norepinephrine, and serotonin. Now, a little bit about all of these. They're all basically protein-based. They all require certain nutrients in order for your brain to manufacture them. Your brain doesn't produce these without some help from what you feed it. Serotonin, for example. That 5-HT stands for 5-hydroxytryptophan, if any of you like to write those big things down. 5-hydroxytryptophan. Anybody ever heard of tryptophan? Turkey. People talk about it at Thanksgiving. They say it's the tryptophan. If you eat too much turkey, you get sleepy at Thanksgiving. I think there's probably other factors involved. Too much football, too much wine, I don't know. But that's another form of psychopharmacology. But tryptophan, the T in that 5-HT, is necessary for serotonin production, or serotonin synthesis, if you want the chemistry word for that. So what do you think is likely to happen to the serotonin levels in your brain if your diet, what someone yesterday just referred to, I thought this was creative, as the Speedway diet? Now, I'm not picking on Speedway. You could pick on any convenience store. And I said, well, naively, I said, what's that? And they said, a big gulp and a bag of chips. That's the Speedway diet. How much tryptophan do you think is in the Speedway diet? 0. If I'm feeding myself just that stuff, it's going to make it more difficult for my brain to produce serotonin. Why do you need serotonin? Well, for a gazillion things, but one thing is it contributes to healthier mood. That's why it's tied to the depression, anxiety thing, right? So one way, if you want to feel better, is eat better. And in working with clients, if you have someone who struggles with depression or anxiety, one of the really sensible interventions is to look at some of those basic lifestyle things, because you need some tryptophan in your diet to produce 5-hydroxytryptophan in adequate levels. So, but they're all protein based. So it can be helpful to all of us to be attentive to that you're getting some healthy protein in your diet on a regular basis. Now, that's not all that difficult. There's lots of good sources: dairy products, nuts, lean meats, tofu, if you're into that. That's good, stuff like that. But one way or another, they're all protein-based. Norepinephrine. Have you ever heard the word epinephrine? Do you know another word for epinephrine? Adrenaline. So norepinephrine is actually a form of adrenaline. The prefix nor refers to nerve, so it's a form of adrenaline that's produced by the nerve cells in your brain. What does adrenaline do when you get a surge of it? It gives you energy. So what do you think norepinephrine tends to do? Tends to be an energizer. So if your norepinephrine levels have depleted, guess how you tend to feel? Lethargic. So just something to keep in mind, that they're all protein-based. Now this is another way of looking at the synaptic transmission. So we add a little more detail to this. So imagine those red particles are serotonin. This particular nerve connection is a serotonin connection. So the yellow cell from which the serotonin originates synthesizes, creates, builds the serotonin from those key components, stores it in little pockets called vesicles, and when an electrical nerve message is sent along that yellow axon, the long part of the nerve, that electrical chemical message causes those vesicles to rupture, and it releases the serotonin into the space which is called the synapse. The serotonin is transported across the synapse and fits like a key in a lock. It's got to have a specific shape. Fits into the receptor sites, which are represented by those green spaces that the red stuff is filling. And you notice how in this graphic the red dots are almost like shaped like crosses or four-leaf clovers or whatever you like. And the receptor sites are a complementary shape. That's exactly what happens. Serotonin has a serotonin molecule has a certain shape. The receptor on the receiving cell has a shape that it fits into. And when enough of those receptor sites are filled, it causes an electrical chemical reaction on the next cell that in turn sends a message across its axon, its wire, and continues that process. Now, how fast do you think this happens? Microseconds. Because if, for me to be able to do this, there's all sorts of nerve messages that have to go zipping through my body. And there might be hundreds of those synaptic interactions between standing here and saying, I think I'm going to jump, and actually doing it. So it's really amazing. And when you really step back for a moment and think about this stuff, it should be it's a bit humbling to me that it works at all. Because right at this very moment, while we're in this room, you have tens of thousands, maybe millions of these synaptic actions happening right now, this very instant, to keep your heart going, your lungs going, your thoughts going, your eyes going, everything. It's all tied to these sorts of synaptic chemical actions. Wow. I used a word earlier, it's a very active word, and I also used that word by choice. I said the serotonin in this example is transported across the synapse. It doesn't just passively sort of float across. There are actually transporter chemicals that latch onto it and drive it across the synapse, so to speak. And those transporter mechanisms can also be part of the action of a particular medication. It can also be related to the person's problem. For instance, there's a gene called the dopamine transporter gene. That makes sense. That in people with ADHD, they often have a different form of that gene than people who don't have ADHD. They have a form of the dopamine transporter gene that doesn't work as well. You might use this analogy. For some people, their dopamine transporter gene builds a transport mechanism that has a turbocharger under the hood. Some people are driving an old Yugo or something. It doesn't work real well. They try to start it up. So there's the transport issue that may affect what's going on at the cellular level in someone with ADHD. And we'll talk more about that. So that's kind of that's where all the action's happening at the cellular level with all the medications we and others may be utilizing. Question. The label says no known mechanism of action. Okay. That means we really don't know how it works. But there's sufficient data that the FDA thinks it does, but we don't know exactly how. How do you reconcile those two things? I'd reconcile them this way. Every psychiatric medication we know that does anything, any medication that affects any aspect of brain functioning has to be acting at the synaptic level because it's the only place, probably the main place it can. But we don't really know exactly which chemical it's affecting or which receptor types it's affecting. So there's a broad understanding that fits with what we've talked about, but a specific understanding of exactly how that particular medication is working is still unknown. So we don't know the specific mechanism of action. Still trying to figure it out. So here are your broad types of so-called antidepressants. Pharmacology experts would prefer, instead of talking about antidepressants, we use terms like it's an SSRI, it's an SNRI, because that leaves it open to being used across those rigid categories. Of course, that's a little trickier. It's a little more complicated. You'd have to be able to explain that to a client. You say, well, it's really not just an antidepressant. It's an SSRI. Let's talk about what that actually means. Your specific serotonin reuptake inhibitors, your SNRIs that affect both serotonin and norepinephrine. And then we've got some ones that are kind of atypical. They're oddballs, for lack of a better term. And then there are two classes that are older that aren't used much, but you may see them occasionally, and those are your tricyclics and your MAO inhibitors. A quick word about MAO inhibitors, because we're not going to talk a whole lot about them, because they're rarely used these days, except when kind of everything else doesn't help much. But MAO, monoamine oxidase, all right, you chemists or biologists, when you see ASE at the end of a chemical name, what is it? I'll be so impressed if somebody gets this. Oh, well, you're a nurse. You get away with it. Oh, Catherine said it's an enzyme. Amylase, lactase. There's one for anybody who's lactose intolerant. Lactase. Okay, lactase is the enzyme that breaks down lactose. And what does an enzyme do? Hold on, Catherine. You can see why you're in mental health. Chemistry wasn't your subject.
Does it break down?
It's enzymes accelerate chemical reactions. They speed up chemical reactions. So MAO, monoamine oxidase, breaks down what things called monoamines, which, let me give you the translation. MAO breaks down some of these neurotransmitters. It's one way your brain turns them off, by using MAO to break the transmitters down so they don't continue to resonate in your system. You don't want a neurotransmitter just acting continuously with no way to turn it off, because you can get things like Parkinson's type symptoms where a tremor continues. You can't stop it. Ideally, with these medications or whatever you want, or any sort of neurotransmitter activity, you want it to do its thing and then stop. The stopping can be just as important as the starting, or else you can get a certain amount of neural chaos going on. MAO is just one way, among others, that we will talk about, that your cells turn off these actions. So an MAO inhibitor prevents the enzyme from breaking down the neurotransmitter, so the neurotransmitter then acts for a blank period of time. What's in the blank? Longer. If you inhibit the enzyme that slows it down, it will act for a longer period. You everybody got that? I know it sounds complicated. Don't worry about it too much if you don't get it, because you're not going to see patients on these very often anyway. Antidepressants, that's the official category. At any given time, about 13% of Americans take them. Does the second bullet point surprise you at all? That only 40% of people who are prescribed a quote-unquote, air quotes, antidepressant have ever been actually diagnosed with depression. Does that surprise you? Maybe not, because what we've already said, that they're utilized for a variety of other things. There's really two issues going on there. One is the one we've said, that antidepressants aren't just antidepressants. There's also just the issue of people not being formally diagnosed with a depressive disorder, which often happens in primary medical care settings. I'm not saying the doctors are being bad doctors. It just may not formally appear in the record. But I like that bullet point because, again, it sort of reinforces that message that it's not just, they're not solely used for depression per se. You familiar with some of these? You have the slides, so I'm not going to read them all to you. I gave you the list of some of the most commonly used antidepressants, or SSRIs, I should use that language, and their generic names. So you've also got some additional handouts in your packets with some additional pharmacology guides that we'll make sure you folks have. But I want you to have the generic names too, because a lot of times clients will take generics because they're way less expensive, and you might not be familiar with which is which. So you've got that information. What do they do? Let's take it apart. SS, specific serotonin. What do you take from those two words? Specific serotonin. Yes.
It selects
Good. That's probably true. It works on, there are various types of serotonin, and it's selective as to which ones it affects. Probably, though that's not actually known, not necessarily a known mechanism of action. What it means is that these medications are intended to only specifically affect serotonin receptors, serotonin synapses, serotonin cells, whatever term you like. And they're intended not to affect any of the other neurotransmitters like norepinephrine, for instance. So it's specific to serotonin. Just trying to keep you on your toes. Anybody guess why I highlighted Paxil? The reason is it was a reminder to me to tell you something about Paxil. You probably will notice clients you see are more likely to be on some of the other ones. It's the one that carries the highest risk of adverse effects, especially in youth. Remember those stories of younger people taking SSRIs and becoming acutely suicidal? It made them worse. Most of those incidents were Paxil related. Now, it's always anecdotal. You can never generalize from one incident. But one of the more tragic things I've ever been involved with was a 16-year-old at one of the Fort Wayne high schools who had no known history of suicidality, who was prescribed Paxil after she became more acutely depressed when her boyfriend dumped her. She was prescribed Paxil and died by suicide within 48 hours. One broad thing you can say about these medications is their outcomes, that's a better word, are much less predictable in young people, especially under like the age of 16. Nobody really knows why, but there's a small percentage, but a significant percentage of young folks who can have this increase in suicidality, typically within the first 2 weeks of starting one of these medications. These medications have a black box warning. Look at the page that comes from the pharmacy for any of them. There is a black box on the pharmacy information that has a specific warning about the possibility of increased suicidality, especially among youth, again, during those first couple of weeks. And it specifically says that family members and other practitioners should be extra vigilant during those first couple of weeks when a child or adolescent is placed on these. Paxil is the one that was mostly associated with those reports. So I say that to you because you work with people. You might be the person who finds out that a young lady from one of the local high schools who's 14 has just been placed on this by maybe a primary care physician whose intentions are good, but whose familiarity is not all that high. And you want to be somebody who's heeding the black box warning and helping the family and ourselves pay attention to what happened. It might help her, but it might not. And especially if you see people on Paxil, I would encourage all of us to be extra vigilant. It's one of the reasons a lot of physicians just don't use it much anymore because of this risk. I'm jumping ahead a little bit, but this is a good enough time to mention it. There's only one SSRI that is considered safe for youth that has less of these concerns. And there's a research body to support that conclusion, and that's Prozac, fluoxetine. If you're going to use an antidepressant with somebody who's 13 or 14, unless it's contraindicated, unless there's some other compelling reason not to, Prozac/fluoxetine is usually your medication of choice. It's the one that the FDA would recommend. Now, again, remember that list of considerations as to how a physician and nurse practitioner chooses a medication? There could be other things that override that, but all things being equal, what I said about Prozac is accurate. What's different about the structure of the brain, and how would an SSRI, somebody who's suicidal versus somebody who's not, nobody knows why. Part of the problem is it's how do you research the subject, because the people affected are deceased, and anything, it's just retrospective. I know it's not a satisfying answer, but it's one of those kind of things that it shows that the subtlety of our knowledge of how these things work in individual brains is pretty limited. Why would it affect this kid and not that kid? Maybe there's some genetic factors, but again, I'm just speculating. I guess at this point, the state of the art is just be alert. And if there's a decision for a good reason to use an antidepressant med in a young person, coach the family, and as providers ourselves, be paying attention, especially during those first couple of weeks. Now, it's not common. It's rare, but one preventable death is way too many, right? I think we all agree. So, and if for some reason you see a young person put on Paxil, I want everybody in this room and everybody who's virtually in this room and anybody who's watching the recording on YouTube, I want an alarm to go off in your head. I mean, maybe it's a good medication choice, but you should question it, and at a minimum, just be super alert to what happens in a young person. Now, what I said doesn't seem to be true in people who are 18 or adults, because an adolescent brain is very different than an adult brain. There's so much change going on during those early years that you can get responses in a young changing brain that you don't get in a more mature one. Zoloft made you feel really kind of flat, and other medication helped you feel better. Sure. I'm not an MD or a nurse practitioner. I don't prescribe, though I've studied this stuff for a long time. There is some subtlety to choosing which of these medications probably makes the most sense for any given individual, but it's an inexact science, all right? Broadly speaking, if you elevate serotonin levels, it doesn't make you feel happy. It tends to make you feel pretty more mellow. It's been associated, elevated serotonin levels have been associated more with feeling more at ease, but not kind of excited. In fact, we'll talk about it later, but it may even inhibit excitement. So it's more of a mellow kind of feeling. It's a little bit more peaceful. Okay, you get that? Norepinephrine, we're jumping to talking about jumping ahead to talk about the SNRIs, the medications that affect both serotonin and norepinephrine. These impact the action of both of those neurotransmitters. Norepinephrine, remember I asked you earlier, what's another word for epinephrine? Adrenaline. What does adrenaline give you? Energy. So perhaps if I was suffering from, let's say, a major depressive episode, and I was more lethargic, and I needed an energy boost, one of these might be a better choice for me, because the action on norepinephrine, epinephrine, adrenaline can help give my nervous system a bit of an energy shot. Not recommending Red Bull with that comment. Speaking of psychostimulant, we'll get to those. On the other hand, there are forms of depression where someone is more agitated. They're pacing, they're fidgety, they're not sleeping. Probably might not make a lot of sense to give me an SNRI. I've got enough restless energy already. So you can think of serotonin somewhat loosely, okay, as being more the mood element of depression, and norepinephrine more the energy element of depression. And maybe I might choose an SNRI if I've got somebody who's got a lot of lethargy along with the depressed mood. But if I need an energy boost and I'm just taking an SSRI, it might make me feel kind of mellow, but it might not get me out of bed or get me a little more energized and motivated for my day's activity. So an SSRI, we talked about the SS. It specifically affects serotonin receptor. Well, what about the RI? Reuptake inhibition or reuptake inhibitor. What's reuptake? Well, reuptake is one of the ways in which a neurotransmitter is deactivated, which is a good thing. Anytime any sort of nerve action happens, you want it to happen and then you want it to cease. Again, think of Parkinson's disease as an example. Some of you have had family members with movement disorders, tremors and Parkinson's symptoms. What seems to be going on with that is the mechanism that turns off the message, move your hand, doesn't work. So your hand just keeps moving. We want to send the message and then we want to stop it so we don't get that sort of resonance in the system. So there's lots of ways that neurotransmitter actions are stopped. One way is certain enzymes that break down the neurotransmitter. MAO was one of them, okay? That enzyme breaks down a number of these neurotransmitters. But an even more common mechanism that stops the message is what's called reuptake, and it is just what it sounds like. Remember we said the electrical message comes along the axon, the nerve fiber. It causes those vesicles that contain the neurotransmitter to break open. It is then enters the synaptic, that space. It's transported to the receptors. It plugs into the receptors like a key in a lock, and it turns on the next cell, if you will. Well, you don't want the neurotransmitter chemical to just stay in those receptor sites forever, or it's going to continue to cause that nerve cell to fire and fire and fire and fire. That neurotransmitter has to be pulled out of the receptor sites. The key has to be taken out of the lock. So there's a transport mechanism that grabs those neurotransmitter molecules, pulls them out of the receptor sites, transports them back into the cell where they came from so they can be recycled. Called reuptake. So it goes out, it does its business, and then it's transported back in. So reuptake is pulling the neurotransmitter back into the cell from whence it came, removing it from the receptor sites. Well, an SSRI, specific serotonin reuptake inhibitor, it slows down the reuptake process, which means the serotonin in this case stays in the receptor sites longer. So it acts longer. So one of the myths about SSRIs and antidepressant drugs is that they boost your serotonin. You get more of it. Not really. They allow the serotonin you have to act for a longer period of time, which kind of has a similar effect as if you had more of it, because it stays in its active state for a longer period of time. So just to use some completely arbitrary numbers, imaginary, if I had 5 units of serotonin, and because of this medication, it acts twice as long, it's almost as if you had 10 units. 5 times 2 is 10. Advanced mathematics. We can handle that one. This is a list of some of the more widely used SNRIs. They act on both serotonin and norepinephrine receptors. Okay? What I said about energy and mood applies here. I think they're good medications of choice for someone who's got a lot of lethargy in association with a depressive disorder. A little joke. Can you read it? Will I get a laugh? I love that cartoon. What this is called an adverse reaction or a side effect. That's just a little bit of a joke. Okay. So it's a segue to looking at this list of potential side effects. There is no such thing as a medication that has zero potential side effects or potential adverse reactions. It would be awesome if there were a medication that had all sorts of good benefits and no risk of anything happening that you don't want. The good news about SSRIs and SNRIs is side effects are usually pretty modest, and some people don't notice any. So compared to some of the meds we're going to talk about today, these sorts of reactions are often less of a problem. I want to talk about sexual dysfunction for a moment because I believe one of the things we don't do very well at Bowen is talk about sexuality, and this is an opportunity to challenge that. SSRIs and SNRIs, one of the main reasons people stop taking them is sexual side effects. And we got to be aware of that, because if I really have a serious depression and medication is part of the solution, we've got a dilemma that we need to help people deal with. These things can be, it's fairly common to have sexual side effects. What are the sexual side effects? Well, when you boost serotonin, you don't increase excitement, you kind of increase mellowness. And mellow and arousal are not the same thing. They're very different. Kind of like, hon, I'm feeling romantic tonight. Yeah, not really. I'm just feeling kind of mellow and just want to go to bed. So have a nice night. Yeah. And so it can reduce sexual excitement. They also can inhibit orgasm in both sexes. Some men will experience some inhibition in erection, slowing of erection. It's not sexual dysfunction. It's not erectile dysfunction in the usual sense, but it's a slowing of the erectile response. People tend to be inhibited about bringing this stuff up. They don't talk about it with us. They're feeling shameful. So we would do well to be the ones who ask. You started a new medication. How's it going? Well, okay. Have you noticed any side effects? Not that I know of. Okay. Well, I just want to review a couple of these. Pull out your slides. I want to review a couple of these with you to make sure that you're not experiencing these, because many people, when they have these things, are afraid to tell their doctor, and then they choose to stop taking a medication, which may be a problem. Are you having any headache? Not really. Nervous, agitated, and then we get sexual, and any sexual effect? What do you mean? Well, let's suppose the male client. Some men notice that when they start taking Prozac, that it affects that they're not as interested in sex, or they're having more trouble responding sexually, any of those things. Not that I realized. Okay, good. How about insomnia? But if we don't be a little more proactive in bringing it up sometimes and just dealing with it like any other medical thing, people won't. And I'm going to challenge all of us. If we're too nervous or hung up to raise those questions, then we got to look in the mirror a little bit, because it's a medical issue that can stand in the way of people taking medications that are maybe critical to, some cases, life and death. The response you will often get is relief. Oh gosh, thank you for asking. I thought it was only me, and I was afraid to say anything. Say, well, I'm not an expert on these things, but I'd like to communicate that information to the nurse for your next appointment with the doctor. Maybe we can move up your next med check so you can take a look at that. Because switching from one medication to another might alleviate the problem. And then the person's more likely to adhere to their medication, which could be really important. Don't combine with alcohol or other drugs. You're going to see that at disclaimer for almost every one of these lists of side effects. We'll talk more about it when we talk about medications for addiction. There's one particular a herbal remedy can be a real problem with people who are taking depression meds. St. John's wort is a flower, and it's used, and it does have some legitimate antidepressant properties that some research has supported, but it can really mess with prescription depression medication. So people should not use St. John's wort with this. There are some other broad food-drug interactions we'll touch on toward the end of our conversation this morning. Alcohol pretty much messes with just about everything. So it's not a good idea, and it includes these. One of the problems is potentially excessive sedation or poor absorption. You're going to see also time and time again that a lot of medications, psychiatric and non-psychiatric, have to be monitored more closely or used more cautiously with anybody who's got any kind of kidney or liver dysfunction, hepatitis or whatever. You know why? Your liver and your kidneys are the main organs that metabolize breakdown drugs. In fact, if you study any particular drug, they'll often say it's metabolized through the kidneys or it's metabolized through the liver. So if my kidneys and liver have a problem, the prescriber needs to know that, because it may affect drug choice of medications and dosing and monitoring thereafter. So if you have any clients with some level of kidney failure, it would do us well to make sure the prescriber is aware of that. Atypical antidepressants. I'm not going to go through all these in a whole lot of detail. They may work on dopamine systems or GABA systems. These are kind of some of the antidepressant oddballs. Let me just talk about one of these as an example and what it says about what we know and don't know about depression medication. Wellbutrin is marketed as a depression medication, but it has no known effect on serotonin or norepinephrine, which are the two neurotransmitters that are usually associated with depression and antidepressants, right? What is its mechanism of action? It's a dopamine reuptake inhibitor. It increases dopamine activity. And dopamine isn't typically associated with depression, but for some people it's as effective as any of the other ones. Why? Every brain is different. That's probably the best answer I can give you, is every brain is different. Wellbutrin is also marketed as Zyban, which is an anti-smoking medication that helps with that. It's also been utilized to treat ADHD at times. So it's atypical in that it's considered, it's approved, its primary FDA approval is as a depression med, but it's dopamine active and not related to that. There is actually a medication that's marketed in Europe that is approved in Europe as a depression medication. And get this, it's a specific serotonin reuptake enhancer. It has exactly the opposite mechanism of action as an SSRI, which inhibits reuptake. This speeds reuptake. How the heck do you reconcile that? If you really want, I'm not sure I would advertise this, but if we really want to look at all this confusing information, try to distill it down to some statement about depression meds, is we really don't know how they work, except that they all kind of do this. I'm going to illustrate this physically. They kind of basically go. They shake up something in our brain. And as strange as it sounds, that may end up ultimately being the thing that antidepressant meds have in common. They take a brain that is somehow stuck in a depressive state and kind of give it a bit of a whack. Why would ECT, electroconvulsive therapy, or magnetic brain stimulation, which is another intervention for depression, why do they all have demonstrated benefits? What do they all have in common? I'm telling you what we do know, but understand there's a lot of unknowns. And the only common theme seems to be we're doing something to get a stuck brain unstuck. And maybe there's something to that. You've got the information about how most atypicals work. They also may affect GABA and some of those other things. Tricyclics. Tricyclics aren't used a whole lot anymore because they tend to have a poorer side effect profile. The reason they're called tricyclics is because if you actually look at them, the molecule has 3 circular atomic structures in it. It's just a description of the shape of the molecule. They're used sometimes, especially when some of the other ones don't work. These days, they're often more likely used for chronic pain. Tofranil or imipramine is actually used these days probably more often for bedwetting because it has a curious side effect. It reduces the amount of really deep sleep somebody has, and it's during the really deep periods of sleep when someone's more likely to bedwet. So if you limit the amount of time that person spends in that super deep sleep state, they tend to wet the bed less often. Of course, there's a question that really deep sleep is therapeutic, so there might be some effects of reducing the amount of time I spend in my deepest state of restorative sleep. So you're probably not going to see these used a whole lot, but maybe more for those applications than depression per se. Mechanism of action isn't terribly well known, but they seem to work more on norepinephrine and serotonin. Monoamine oxidase, MAO inhibitors. I doubt you're going to see these very often, but you may see them occasionally.